So our GI tract is a very important organ in our body. It starts from mouth, as you can see this picture starts from mouth, then it goes into food pipe, then it goes into stomach, small bowel, and large intestine. This is a bigger picture. So this is your food pipe, this is your liver. Now from food pipe, food goes into your stomach. From here it goes into tiny tubes, first into these tiny tubes, we call it a small bowel. From here, through the connection, it goes into this large bowel, we call it colon, okay? Now, what is autoimmune system? Everyone, we have immune in our immune system, which helps in fighting off the infections or bad cells. And some also, it is kind of a way of protecting us from developing cancer. However, what happens sometimes, your body start attacking your own cells, which means that your autoimmune starts getting flared up, and this is what we call autoimmune, because your own body starts attacking your different parts of the cells in different part of the body. In GI, in inflammatory bowel disease, what starts happening, they start attacking different parts of your whole gut lining, and that's what we call inflammatory bowel disease, because now what happens, it start developing inflammation, irritation of the gut lining, which can cause ulcers and soreness throughout in your GI tract.
Hello listeners, welcome to another show of Doc Talk Live. Doc Talk Live is a health show dedicated to educating its listeners about different health topics every week, and we have another great show for you this week. And we, as usual, we always bring on medical experts to answer commonly asked questions. And like always, we're on Facebook Live on Wednesdays around 5:30 p.m. And you can find more information about the show on our Facebook page, as well as Instagram, Twitter, YouTube, and on our website, doctalklive.com. That's DOCTALK live.com. Also, you can go back and watch previous episodes on various platforms, podcast platforms such as Spotify, iTunes, and iHeartRadio. My name is Dr. Samir Nangia, and I'm hosting today's show. And I'm really excited about today because we have a familiar face in the studio. I think this is a very important topic because there's an increasing trend in the incidence of pediatric inflammatory bowel disease in the United States and Canada. And in the studio today, we have Dr. Sadaf Sagir, who is, again, and thank you for coming back, and discussing IBD in children, which is a very important topic. So Dr. Sagir, welcome back to Doc Talk Live. Always excited to have you here in studio. And I know you're very busy, so thank you for volunteering your time to educate the community. And so why don't we start out, for those who have not heard you before, can you tell our listeners a little bit about yourself?
Sure. Thank you. First of all, thank you so much, Samir and Talk Doc Live, for having me on air today and giving me this platform to spread my knowledge to all the audience and all the parents. Of course, I would love to share a brief information about myself. I am Dr. Sadaf Sagir. I am a board-certified pediatric and general pediatric and pediatric GI specialist. So being a pediatric GI specialist means that I have been trained to diagnose and treat your child with GI issues, which can be anywhere from mouth, food pipe, stomach, or intestines. It can include chronic diarrhea, constipation, feeding difficulties, weight gain, weight loss, basic liver issues, celiac disease, food allergies, inflammatory bowel disease that we will be discussing today. I'm currently practicing in Arlington area. I do have plans to open up satellite locations in different areas of DFW, and I'm currently seeing many patients from DFW, and in fact sometimes from Waco and far off places, because I can do some televisit as well as clinic visits as well. We take almost all commercial insurances, self-pay, and Medicaid as well, along with TRICARE as well. We are able to schedule patients within 24 to 48 hours. And my staff is great. They help they will work great to help you out in getting scheduled. Our office number is 214-630-4320.
Well, it's always a pleasure to have you here on the show, and I guess we have a lot of firsts today on our show. I mean, I believe in 7 years we've never had a diagram on our show. So for those who are watching on Facebook, we have a picture of a diagram that we will be referencing, and we will also get a picture of that. So for those who are listening on our podcast can reference it. And then also we were talking about inflammatory bowel disease, which is not commonly talked in the last 7 years. So this is great for those listeners who have children with inflammatory bowel disease. So why don't we get started? Can you tell our listeners a little bit about what inflammatory bowel disease is?
Sure, Samir. Before I start with inflammatory bowel disease, I just want to go over briefly how our GI tract is and what do we mean when we are talking about inflammation or autoimmune. So our GI tract is a very important organ in our body. It starts from mouth. As you can see, this picture starts from mouth, then it goes into food pipe, then it goes into stomach, small bowel, and large intestine. This is a bigger picture. So this is your food pipe, this is your liver. Now from food pipe, food goes into your stomach. From here it goes into tiny tubes, first into these tiny tubes, we call it a small bowel. From here, through the connection, it goes into this large bowel, we call it colon. Okay. Now what is autoimmune system? Everyone, we have immune in our immune system, which helps in fighting off the infections or bad cells, and some also it is kind of way of protecting us from developing cancer. However, what happens sometimes, your body start attacking your own cells, which means that your autoimmune starts getting flared up, and this is what we call autoimmune, because your own body starts attacking your different parts of the cells in different part of the body. In GI, in inflammatory bowel disease, what starts happening, they start attacking different parts of your whole gut lining, and that's what we call inflammatory bowel disease, because now what happens, it start developing inflammation, irritation of the gut lining, which can cause ulcers and soreness throughout in your GI tract.
Well, that was a very good explanation of inflammatory bowel disease. I think patients, one of the first questions they probably ask you is, what factors play a role in causing this disease? Like, why am I getting it?
Sure, and this is a very common question I get something from different parents, of course, when they are coming to me. One thing I'm going to mention is there's no any one particular factor that is going to affect causing this. It's a combination of three most common factors, and as per there is still research going on, no any one particular has been shown to be very much just causing it. So these three factors are genetics, your own body system, immune system, and your own body system, like how it is fighting off the infections, and environmental triggers. When we have a combination, now I'm going to break it down with genetics. IBD patients, at least 1/4 of these patients will have some sort of family history. Someone in the family has had maybe grandparents or parents or sibling with Crohn's disease, ulcerative colitis, but it's 1 in 4. That doesn't mean that you don't have a history, you cannot have it. You can still be the first one in the family to have it. Okay. The second thing that is the immune system. Now everyone has immune system to fight off infection. Usually what happens, you fight off the infection and your immune system calms down, everything goes back to normal. In some individuals, we call it immune susceptibility to the infection, which means the way your immune system is, after getting hit by the infection, it does not go back to normal self, and it starts the cycle of autoimmune, start one into the other, just constant irritation, and now you have inflammation throughout it. The third thing that is called, is known to be causing it, is environmental factor. What it means is life history or diet, saturated fats, red meat, less fiber and veggies in the diet, cigarette smoking. So when you have someone who has a genetic history and now their own immune system is not very strong, and on top of it there is very unhealthy diet, you are at risk of developing IBD.
Well, that's a great explanation. And something that when we think of IBD, we hear these words, ulcerative colitis and Crohn's. So if you can briefly tell our listeners, what's the difference?
Sure, Samir, and I think this is why I brought this, because it helps in understanding why one is different from the other. So IBD is a big umbrella, and underneath this there are two conditions that's happening. One is ulcerative colitis and one is Crohn's disease. Now what happens is, the difference is, ulcerative, this is, as I remember, food pipe, stomach, small bowel, and this large bowel is the colon. In ulcerative colitis, mainly your large bowel is involved. This is colon, okay? Itis, anything that has itis in it, it means inflammation. So in ulcerative colitis, The thing is, the inflammation usually starts from the bottom. This is where you poop out, right?
Mm-hmm.
Yeah, it starts backward, and it's like a very smooth throughout the whole lining is involved. It involves the inner lining of your guts.
Sure.
And that's how it goes. Usually it can go backward all the way to here. And sometimes in 10 to 15% of the cases, you can see involvement of some ulcerations over here. Okay, so ulcer and soreness throughout here. In Crohn's disease can be anywhere from your mouth, food pipe, stomach, and mostly involves the small bowel, but it can also have involvement of the colon also. So that's the major difference, right? Secondly, in a Crohn's disease, you can have patchy disease area. So you can have redness here, you can have inflammation here, just a food pipe can be involved. Thirdly, what happens is it involves full thickness of the muscle. So Crohn's disease is more dangerous because when you have full thickness of the muscle involved, it can cause stricture, narrowing, obstruction, many things, or even connection between the two guts happens. We call it fistula. So this is the main difference.
So location as well as thickness.
Exactly.
Okay, great. So I think the most natural question to ask you next is, how do you know you have it? So
yeah. So this is a very so when you have inflammatory bowel disease, the presentation usually I see, and I can talk about the pediatric patient. Lately, I have been seeing many cases of pediatric in my clinic. As young as I can say, there's one thing we early onset, they can have anywhere from infancy. It's rare, but that does happen. The youngest I have seen in my clinic as of now is a 4-year-old child. So they can have, and the age-wise I'm going to mention, you see more of these symptoms that I'm going to be talking about in their first decade of life, which means during their teenage year, at 12-year-old all the way to 19, 20, or third decade or the second decade of life, which means in their early 20s. And then there's a certain population where you see there are another peak in 50s to 60s years of people, which is going to be an adult population. So in pediatric, when they're coming, you can have a child who just on and off started off with diarrhea. That's the most common condition, common symptoms I see. On and off diarrhea, now later started having some cramps along with some blood or mucus in the poop, right? You can have a child who is just slowly getting off the growth chart with a poor weight gain, and they can vary in symptoms. Abdominal pain and diarrhea is the most common one. The other things can be on the labs, you are found to have iron deficiency, anemia, or just some macroscopic blood in the stool. This could be the early Crohn's going on. Height growth can happen. These are usually the ones. It can affect, in some cases, just a skin lesion, because Crohn's disease, ulcerative colitis, is not the condition only related to GI. It is mostly, but you can have extra GI issues also, which means you can present to the clinic with a very rare ulcer you can have, and with the biopsy you can find out there is actually connection with the ulcerative colitis. You can have a liver involvement where a child is showing up just with the raised liver enzymes or having a jaundice. So there are multiple presentation, but blood in the poop, diarrhea, belly pain, on and off going on, gradually getting frequent, that's the worrisome, and weight loss.
So I'm going to give you a scenario. You have a 8-year-old who's having these symptoms, belly pain, blood in the urine, blood in the stool, and diarrhea. So what would be the series of steps that you would do in diagnosing this?
And that's a very good question, Samir, because I deal with this on every basis. Exactly. So when a child is coming to my clinic, it's not that we as a doctor, we just jump to one conclusion. Of course, there's going to be a set of tests that we do. So if someone is coming with the belly pain and all this, especially with diarrhea going on, you always want to rule out if this, it could be as simple as infection. You always want to have a stool test done. As well as now in these cases, I check for presence of inflammation within the stool also, fecal calprotectin that we go. Besides stool tests, we always do blood work. When I'm doing a blood work, I'm a little bit more thorough, because then I'm looking at your CBC count to look at your hemoglobin. And so you have been not obviously, but losing macroscopic blood, and now you're becoming anemic. Kids who are dealing with Crohn's or ulcerative colitis, they are nutritionally depleted over a period of time. So albumin is something that can tell us also, though they are low on that counts. And then I'm looking for inflammatory markers in the blood. I'm looking for your thyroid, your sensitivity to gluten in the diet, because these celiac disease, food allergies, sometimes they can overlap the same symptoms with the abdominal pain, diarrhea, nausea, vomiting in these kids. So while you are testing, you do the whole battery of tests, especially in a pediatric. You don't want to keep on pricking them again and again. So food allergies, celiac disease, thyroid, and basic labs.
So there's a differential diagnosis that we... Yeah.
Once I have these, if the stool test is negative, right? So the question is, in a way, how do we test them, right?
Sure.
How do we know that this is Crohn's? If blood work is, even though a little bit concerning, or poop test is showing me there's no infection, and now I have a child with these symptoms, then the next step goes to endoscopy, which means that we are using a tube size of my finger with a small light and camera at the end. We do upper endoscopy and we do lower endoscopy. We call it colonoscopy. In that one, that tube goes through your food pipe, from the mouth through the food pipe into the stomach, all the way to the first part of the small intestine we call duodenum. On this way out, what I'm doing, I'm taking a scratch, like just a small biopsies, to look under microscope what is going on. Now that is known as upper endoscopy. We use then a different tube, which is about another size of my finger. We go from the bottom, and our goal is, remember, ulcerative colitis, the moment you enter, you will start seeing these lesions. You go all the way there to the right end, and this is the junction where small bowel is joining your big bowel, right? Sometimes, and this is very important to get into terminal ileum, and part of a small bowel is known as ileum. So terminal ileum and part of the small bowel. Crohn's disease, remember I said that it is going to be in the small bowel, so you take some sample from the terminal ileum, and that really helps you in differentiating between Crohn's and ulcerative colitis, because you can have a completely normal colon, and yet the moment you enter here, you can see pus and all that redness in there. And also throughout the colon, we take these biopsies. So that's how biopsy is kind of gold standard. We see it, and we have the diagnosis, then we start the therapy.
Sure. And so when you're doing the endoscopy from the top or the bottom, are you actually going to always visualize?
Of course. So we have a big camera as I'm
Sure.
going. It's just like I'm using this, but I'm looking at a big screen, and it's showing me everything as I'm going in.
Sure.
Whether there's ulcer sitting, there's any irritation. Food allergies will show me white spots throughout the food pipe. Celiac, this is where the celiac happens, in the duodenum area, first part of the small intestine. You can take some samples from there, and most of the time as we go in, we pretty much know what is going on down there.
Sure.
One thing I want to mention, Samir, here, since the camera, it cannot go into the small bowel unless we are doing a special procedure. So whenever I have concerns for Crohn's, you always want to make sure what's the condition of your small bowel.
Sure.
Because this all could be looking okay, and then yet you may have a small narrowing or stricture developing. So I go for MRI of the abdomen, which is a spatial kind of X-ray, looking thoroughly. I tend not to do CT scan because that's too much radiation for the patient, pediatric patient. MRI is safe magnetic rays, but you can have a thorough look throughout what's going on.
That's great. And so now that we talked about diagnosing, what are like the first steps in treatment?
Okay, so treatment differs based on how severe am I seeing the disease. Is this mild, moderate, or severe? There are medicines, of course. Now there are medicines, category of medicines I'm going to divide here. One that take care of right away a severe flare, like with the blood and severe pains and all that. And then there are medicines, you want to treat the acute symptom, but at the same time you want to start them on a medicine that is going to control their inflammation. Because remember, this is autoimmune. This is like the immune system is flaring and attacking all the cells. So you want to calm it down, right? So with ulcerative colitis, as I mentioned, it starts with the bottom. If this is very raw and rest of the colon is good, then all they need is rectal enema, which means there is this liquid tube, like enema, you push the liquid every night, and it is low. It's not laxative, it's a medicine. So it topically like coats the lining, and it helps in healing. Then there are some medicine by mouth we give them, okay, and which overall works for immune suppression. Sometimes, by the time I have a kid with Crohn's disease, there are many other medicines also, and
Sure.
it's all in a way in working to suppress the immune system. One thing I want to mention, when they are having acute flare, we give them some steroids. Now, these steroids are not the one that athletics or some other do it. So these are safe steroids because you want to bring down the inflammation so child is okay, and we eventually get them off of it because the steroid is not going to be for long term because of side effects. We start them on medicine that is going to control them. Now, whether it is by mouth medicine, most of the time, yes. 5-ASA, you may have heard it, 5-ASA, there are 6-MP, different type of drugs. In pediatrics, there is limited drugs that we can use, right? Because there is side effects related to these drugs.
Sure.
By the time they are coming to me, the muscles are, it's so severe that if for ulcerative colitis, by mouth mesalamine is not working, then I may have to step up the therapy. Now, when we are talking about biologics, these are different category. As of now, in kids, they are approved. Remicade is approved, or there's Humira is also approved. Humira is injections, Remicade is infusions. The difference is they work through a different mechanism, but they are very good in calming down your inflammation and keeping it maintained. If you have a child who's right at the verge of puberty and the disease is just not getting controlled and in this normal small area, sometimes if the medicines are really not working, they do end up getting surgery also.
Sure.
We will be discussing more in the next question. But yes, we start by mouth medicine. Medicine not working, we do infusion. Infusion starts every 2 months. That's how we do it and keep them under control. If the flares are on while they are on infusion or they are on chronic medicine, they can still get flare up. And that's where I want to be clear. Some patients think that, parents think that once you're on medicine, it should never happen again. No. Your child is a regular child, you can still have this infection, or they can have infection on top of it. They can have a C. diff infection. They can have a flare from stress, anxiety, or food poisoning. Anything can just cause it. So you want to control that with 2 to 4 weeks of steroids, and then you wean them off it. We don't suddenly stop it because it may bounce back.
So it's similar to asthma. You have maintenance medicines, and then there's flares that require medications.
Yes. One more thing I'm going to mention. When I'm talking about immune suppressant medicines, these are not like a, God forbid, chemotherapy patient where this is not where we are completely knocking out the immunity. We still have their WBC count is still within normal range. It's not like down to neutropenia, what the medical term is that they are way susceptible to infection. Immune suppressant means, yes, they are still, compared to general population, they are going to be a little bit at higher risk of getting infections, but not like, God forbid, chemo patients.
Yeah, thanks for clarifying
exactly.
that.
That's the most common fear parents have.
Absolutely. I can imagine having kids myself. So those were just joining Doc Talk Live. We're in studio with Dr. Sadaf Sagir talking about inflammatory bowel disease. It's been a great discussion so far. We touched on diagnosis and early treatment medications. And then you were about to talk about that surgery. Is surgery an option?
So good thing is with the new research and more medicines coming up, how much surgery was happening in the past, that has gone down. But yes, as I mentioned, it depends on what part of your gut is involved. So in Crohn's, let's say this is a small part of the diseased area. First of all, main goal is going to be to open up that narrow area, right? But if that is still not functioning, or you keep developing obstruction, or the gut is twisted on it, then it is dangerous to leave it like that. So they would just take that part out and connect the rest, okay? Depending on how sick the gut lining is, what they can sometimes do is leave the opening to the skin, wait for the gut lining to heal, and then they join this back again. And these kids can have normal bowel once it's joined again. However, you may have seen some kids who have this a bag attached to their skin, and that is when some surgeons, they give them time for the gut lining to heal. They poop in that bag, it's regularly replaced, and then eventually they hook that kind of disconnected guts together again. If it is ulcerative colitis or your colon has been affected big time, they can let's say this whole part is affected, they can take this part out and they can attach this part to your anal part. So it's like what part of the gut is involved, that's where it goes. And again, in pediatric, I can say it's very, like, the goal is not to have it, because the early this disease is caught, and the better the chances are that we will be able to avoid surgeries.
Yeah, and so in these patients, these kids who have IBD, Crohn's, and ulcerative colitis, are they at more risk for colon cancer?
Yes, Samir, and actually not in a pediatric, but by the time they are in adult age group, that can sometimes happen. So, but not all of them will happen, but the ulcerative colitis, because it's the colon is the main targeted area that is involved, they are at risk. So usually we recommend that after 10 years of diagnosis, let's say someone has been diagnosed at 10 years, right? So from 20 years of age, they need to have routine colonoscopies like every 1 to 2 years, depending what's going on. In Crohn's also now, as I mentioned, Crohn's can be anywhere from mouth till the end, up to the end. So even though mostly it involves small bowel, sometimes it can involve your colon also. And in those cases, it is more important to be a little bit more regular in terms of screening colonoscopies. And in those cases, 8 years onward, that's what they say to start screening. Now, the guidelines keep on changing. What I'm telling today, it may be different tomorrow. So that's where we are. But as of now, that's what it is.
Well, we have a few minutes left. Time just flew by. And this has been extremely informative. I do want to give you a minute to just briefly, any last words of advice for kids who are dealing with this and parents?
One important thing I'm going to mention that kids who have IBD, please try to avoid unnecessary NSAIDs use, which means ibuprofen, Motrin, aspirin, certain antibiotics. Now, if it's needed, that is fine, but you have to talk to your doctors about it, making sure that they know the underlying diagnosis, like cephalosporins, penicillins, they can got a little bit more irritation of your gut lining. Cigarette smoking, fats in the diet, less fiber, these are another diet changes you want to have. If you are planning to become pregnant, you have to let your doctor know, because like Methotrax said, it can cause more difficulty to the baby.
Well, we have a few seconds left. Just remind our guests, our listeners, how they can find you.
Sure. It's been a pleasure. Thank you so much, and I wish I could talk more. So here's the thing: my office is in Arlington. My contact number is 214-630-4320. We take almost all type of commercial insurances, self-pay, TRICAID, Medicaid, please, traditional and American Group Medicaid. Call our office. We will be able to schedule within 24 to 48 hours. We prefer to see inpatients, but I see patients from all areas of DFW, and it's
well, we hope you come back to our it's been a pleasure to have you here on the show all the time. Very informative.
Of course.
I learned a lot today.
No, thank you. And actually, audience, you guys can always let Samir or Talk Doc Live know what special topics you want me to come by and talk about at GI, because I'm board certified in general peds also. So if anything related to anything in particular you guys need, I'm here for you.
Thank you. Well, thank you for listening to Doc Talk Live Season 7. Thank you, and we look forward to having you guys listen to our show. And at our next week's show. Again, you can find us on our podcast platforms and hear previous shows, our YouTube, and our Facebook, Instagram, and Twitter. So thank you again for being here, and we look forward to having you guys listen on our next topic, next show. Thank you. Stay healthy, everyone.